Department of Perinatology named after Alash Kozbagarov. Topic: Hypertensive conditions during pregnancy. Aim of the lecture: through the clinical case study, pathogenesis, clinical features, and pathomorphology of hypertension related to pregnancy, learn classification, obstetric tactics, principles of therapy, develop and consolidate clinical thinking skills of third and fourth course students of general medicine faculty, faculty of nursing, and faculty of dentistry. Demonstrate benefits of integrated subject study. At the end of the lecture, you will be able to know clinical forms of hypertensive conditions meeting during pregnancy, features of pathomorphological disorders, diagnosed by clinical data, different forms of hypertension complicating the pregnancy. Plan of the lecture: definitions of the hypertensive conditions during pregnancy, clinical case presentation, morphological aspects of chronic hypertension in pregnant women, risk factors and classifications of hypertension caused by pregnancy, clinical characteristic of pregnancy-related hypertensions, features of the pathogenesis of hypertension caused by pregnancy, obstetric tactics from the position of evidential medicine. Hypertensive conditions during pregnancy. It is necessary to distinguish between chronic arterial hypertension and pregnancy hypertension. Chronic arterial hypertension is a disease manifested by hypertension established before pregnancy or diagnosed before 20 weeks of pregnancy and persisting till 6-12 weeks after birth. Morphological aspects. The causes of chronic arterial hypertension during pregnancy are primarily hypertension, chronic inflammatory kidney disease, and neuroendocrine disorders. The main morphological changes in case of chronic hypertension: in the liver, in aorta. Microscopic picture. Hypertension caused by pregnancy is hypertension that occurs after 20 weeks of pregnancy and when blood pressure normalizes within 6-8 weeks after labors. Pregnancy-related hypertension, formerly called Gestasis, late pregnancy toxicosis, is not a disease but a complication of pregnancy. The frequency of hypertension associated with pregnancy in the world up to 8 persons. Risk factors of development. First pregnant woman younger than 18 years and older than 40 years. Extragenital diseases, cardiovascular diseases, diabetes mellitus, obesity, and antiphospholipid syndrome, preeclampsia, eclampsia in a previous pregnancy, preeclampsia in a family history, multiple pregnancy, interval between labors more than 10 years. Hypertension caused by pregnancy. Classification: first, gestational hypertension. Second, preeclampsia, which divided on mild and heavy, and eclampsia. Hypertension caused by pregnancy. Typical clinical signs: arterial hypertension manifested in the second half of pregnancy, proteinuria during pregnancy, swelling upward from the legs. Moderate edema is observed in 50-80% of pregnant women with physiological pregnancy. Proteinuria more than 1.3 grams per day or more than 1.3 grams per liter in daily urine analysis. Arterial hypertension: systolic pressure more or equal to 140 and diastolic pressure more or equal to 90. A double measurement with an interval not less than 30 minutes. Criteria for severity of hypertension: mild hypertension, systolic pressure more or equal to 140 and diastolic pressure more or equal to 90. Medium arterial hypertension, systolic pressure more or equal to 150 and diastolic pressure more or equal to 100. Severe arterial hypertension, diastolic pressure more or equal to 110 and systolic pressure more or equal to 160. A double measurement with an interval not less than 30 minutes. Clinical case. For consultation directed 23 years old pregnant woman with gestational age 30 weeks. Patient doesn't have any complaints, had no diseases in history. She is married, her husband is 25 years old, healthy. This pregnancy is first. She is on D account from 10 weeks. Regularly visits the local obstetrician gynecologist. The results of laboratory and instrumental examination were normal. Objectively, pregnant is active, no visible edema, blood pressure 160/100, pulse 80. The height of the uterine fundus corresponds to the gestational age. The uterus has a normal tone, not excitable. Fetal heart rate is clear, up to 130. In the exchange cart of pregnant woman, there are laboratory examination. Clinical blood test: hemoglobin 112, platelets 280. In urinalysis, density 1020, protein 0.33 per gram per liter, with microscopy of the sediment, leukocytes 1 and 2 in line of vision, and squamous epithelium 3 and 4 in line of vision. Does pregnant woman have established signs of pathology? If yes, indicate these signs. Yes, she had arterial hypertension, blood pressure level 160/110, proteinuria, the presence of protein in the urine at the level of 0.33 gram per liter. By severity criteria, what is the level of arterial hypertension? Severe arterial hypertension. Preliminary diagnosis in pregnant woman. Pregnancy 30 weeks, severe preeclampsia. Does this pregnant woman need hospitalization? She needs emergency hospitalization in obstetric hospital. In accordance with the level order of her regionalization, in which level must be hospitalized this patient? Obstetric hospital or third level. Clinical forms of pregnancy-related hypertension. Gestational hypertension, increased blood pressure after 20 weeks of pregnancy, arterial hypertension without proteinuria, may go into preeclampsia, therefore requires careful appropriate monitoring. Preeclampsia, arterial hypertension, pathological proteinuria. Mild preeclampsia, this is mild hypertension in combination with proteinuria plus edema. And severe preeclampsia is severe hypertension plus proteinuria, hypertension of any severity with plus proteinuria 5 grams per liter or more, and hypertension of any severity plus proteinuria plus one of these symptoms: strong headache, disorder of vision, epigastric pain and nausea, vomiting. Convulsive readiness, generalized edema. Oliguria, less than 30 ml per hour or less than 500 ml of urine in 24 hours. Pain at liver palpation. Increased level of liver enzymes. HELP syndrome. Platelet count less than 100. Intrauterine growth retardation. Eclampsia, the presence of convulsive seizures. These are tonic-clonic convulsions that are not associated with epilepsy or any other known pathology. Morphology of eclampsia. Changes are represented by disseminated thrombosis of small vessels, numerous small necroses, and hemorrhages in internal organs. At autopsy, edema, jaundice, pronounced changes in the brain, lungs, heart, liver, and kidney are found. In the heart, blood clots in the vessels, focal necrosis of the myocardium, and hemorrhage. In the lungs, hemorrhages, edema, and confluent hemorrhagic pneumonia. Edema, blood clots in small vessels, hemorrhages, more often in the subcortical nuclei, and are found in the brain. Morphology of eclampsia. The liver is enlarged, mottled, with numerous hemorrhages. Microscopic examination reveals blood clots in small vessels. Hemorrhages are and foci of necrosis. The kidneys are enlarged, flabby. The cortical layer is swollen, variegated, and the cerebral layer is sharply full-blooded. Symmetric necrosis of the cortical substance of the kidneys is sometimes found. Histological examination reveals common thrombosis and fibrinoid necrosis of small vessels, dystrophy and necrosis of the tubular epithelium of the main sections of the nephron, hemorrhage in the interstitial tissue, especially the pyramids. Death can occur from the liver or kidney failure as well as from disseminated intravascular coagulation and hemorrhages in vital organs. Pregnancy hypertension is one of the main causes of adverse perinatal outcomes, morbidity and mortality of newborns, stillbirth. Pregnancy hypertension accompanied by impaired function of the nervous, cardiovascular, endocrine systems, hemostasis system, fetoplacental system, liver and kidneys. What is the name of this clinical syndrome? Multiple organ failure syndrome. The reason is the presence of a developing fetal egg. The leading role in the development belongs to the inferiority of functional systems that ensure the gestational process and its normal course. One of the triggers is immunological abnormalities in the mother placenta fetus system. The main links of pathogenesis: endotheliosis, generalized vasoconstriction, hypovolemia, violation of the rheological properties of blood, development of chronic DIC syndrome. Violations begin with the vessels of the placenta and leads to the development of chronic placental insufficiency. All the functions of the placenta are reduced: respiratory, which leads to chronic fetal hypoxia; nutritious, development intrauterine growth retardation; protective, development of intrauterine infections of the fetus. Here you can see placenta in this case. In second place in the frequency of damage are the vessels of kidneys. Glomerular permeability increases, proteinuria develops, glomerular filtration is reduced, which leads to oliguria up to acute renal failure. Renal vascular thrombosis with cortical necrosis develops. Hydrophic dystrophy of the convoluted tubule epithelium. Liver damage with preeclampsia and eclampsia. Degenerative lesions of hepatocytes with the development of atrophy of the liver and hepatic coma. Fatty degeneration of hepatocytes develops acute fatty hepatosis. Hemorrhage under the capsule of the liver. HELP syndrome. Macroscopy. The liver is enlarged, flabby, on a yellow incision with a touch of fat. Microscopy. In the cytoplasm of hepatocytes, vacuoles. Outcome: reversible process or with the addition of necrosis, liver failure. Brain damage: cerebral edema and cerebral hemorrhages. Pregnancy hypertension is one of the main reasons of disability and death of a woman, takes second and third place in the structure of causes of maternal mortality. Adverse perinatal outcomes. Diagnostics at ambulatory level. Measurement of blood pressure, urinalysis, and clinical blood test. Tactics at ambulatory level. To make a diagnosis first, and then determine the presence of or absence of indications for hospitalization. Gestational hypertension. Tactics. Planned hospitalization on second level. In the hospital, clarification of the diagnosis and conduct according to the indications. Antihypertensive therapy. Delivery at 37 weeks of pregnancy. Mild preeclampsia. Planned hospitalization on a second level. In the hospital, clarification of the diagnosis and carrying out according to indications antihypertensive therapy. Delivery at 37 weeks of pregnancy. And severe preeclampsia and eclampsia. Emergency hospitalization on a third level. Anticonvulsant magnesial and antihypertensive therapy start in primary care. Emergency delivery regardless of gestational age. With severe preeclampsia within 48 hours, with preeclampsia no later than 12 hours. Pregnancy-related hypertension can be cured. Pregnancy hypertension stops only with termination of pregnancy. List of antihypertensive drugs. Fast-acting drugs is nifedipine and sodium nitroprusside, and slow-acting drug is dopigid. With severe preeclampsia and eclampsia, anticonvulsant therapy is indicated. Delivery. Labor through the natural birth canal preferable than operative delivery. Thank you for attention.